evening, Dr. Shrikant sir and Dr. Ruchika ma'am, and all the panelists and our internal faculties. I take this opportunity to welcome you all on behalf of Hetero Healthcare. I'm Sachidanand Yadav, Divisional Manager for Helion Division, based at Delhi. Sir, first of all, thank you all for the joining for this Dementia Awareness and Management webinar. Talking about the organization, as you all know about Hetero Healthcare, we have the largest R&D wings providing 360-degree solutions. Hetero has more than 25 years of excellence in multiple therapies and present in more than 126 plus countries worldwide. Hetero has more than 200 products across various therapeutic categories such as HIV, oncology, cardiovascular, and neurology. Distinction of bringing 4 biosimilar products to the market. We have manufacturing facilities in 36 plus states, which is pioneering in quality and innovation. Today, we have renowned speakers and talking about Dr. Shrikant Shrivastav, sir, who is Professor and Head of Department for Geriatric Mental Health, KGMU Lucknow. Sir has done MD Psychiatry and FRC Psychiatry from UK, and Sir has MSc from Italy. Talking about Sir's experience, Sir has more than 25 years of experience in mental health sector. Sir has worked in UK, Singapore, and India. Sir has more than 15 years of assessing and treating psychiatric problems in older patients. Sir's key research area is treatment of depression in older adults, taste sensation in adults. Talking about the publications and books, Sir has more than 50 publications in national and international journals. Moreover, Sir has done more than 10 book chapters. Today we have one more renowned neurologist, Dr. Ruchika Tandon ma'am. She is Associate Professor at Department of Neurology, SGPGI. Talking about qualification of ma'am, ma'am has done MD Medicine, MBBS, GS from GSVM Kanpur. Ma'am has done DM Neurology from SGPGI Lucknow. And talking about the experience of ma'am, currently ma'am is working as Associate Professor at SGPGI Lucknow from 2021 to till date. Previous to that, ma'am has worked as an assistant professor at SGPGI only from 2018 to 21. And previous to that, ma'am has worked as assistant professor at KGMU Lucknow from 2015 to 18. Talking about ma'am's publication and books, more than 32 national and international publications and more than 18 book chapters. Ma'am's skills and expertise are in clinical neurology, movement disorder, neurodegenerative diseases, Parkinson disease, adult neurology, and neurodegeneration. Sir, this is all about the introduction of renowned speakers. Sir, I would now request you to kindly take over this forum and share your experience to discuss more on the subject. Over to you, Shrikant sir.
Thank you, Mr. Yad. So, when I was asked to do this webinar, it always puts me in quandary when I don't know the audience and what they want. So I decided to put it in a very clinical perspective, something which we do in the outpatient clinic, at least one patient every day. So I'm not going to be talking about the cutting edge research, but more of a hands-on practical approach to do in the clinics. So I hope you people agree to that. And if not, it's too late to change the presentation. Right.
Sure.
Why the slides are not moving? Okay, that's the outline of my presentations. We discussed about the symptoms and syndromes, go on to the treatment, a couple of slides on the Indian studies which have been done on behavioral and psychological symptoms of dementia, and then how about a case from my own clinic. Right, so this is from a data set of more than 2,000 patients that these 4 syndromes have been identified. And hyperactivity, psychosis, affective, and apathy. And looking further at this research database, we find that hyper and affective symptoms are present in all types of dementia, be it Alzheimer's, frontotemporal, Parkinson plus, Lewy body is there. Whereas apathy is more related to the cholinesterase inhibitors use and psychosis to the severity of the dementia illness. Symptoms in primary care. I put this slide specifically because we have a walk-in clinic. So although we are a tertiary care center, we can get patients who come straight from home to us like in a primary care setup. We find that more than 3/4 of the patients with the diagnosis of dementia will have the symptoms of mood, apathy, hyperactivity. Whereas aberrant motor behavior, agitation, and indifference are present in less than 1/4 of the patients. And that is actually our personal experience as well, without giving you the numbers from my own clinic as an audit, that more of the patients come with mood symptoms or hyperactivity syndrome. I think the latter one is more disturbing for the caregivers. So these syndromes, hyperactivity, it can be aggressiveness, disinhibition, irritability, aberrant motor behavior, or even euphoria. Apathy, as in apathy, or people are eating more or eating less. More of the time, it is that they just do refusal. Depression and anxiety, or hallucinations, delusions, or sleep disorders. Now, I find the last one, the sleep disorders, to be most puzzling when trying to come to a differential diagnosis, which we'll be talking about it in the later slides. So I took this from a big database set where they looked at the symptom frequencies. The ones in the light green, all the bars, are where the patient's symptoms, where the symptoms were present in the patients. Those are the percentage of the patient. And highest was 70% as in apathy or indifference, followed by 50% of agitation, aggression. We are talking about this left-hand side. But the symptom being present and the symptom being clinically meaningful, as in distressing to the patient or the caregiver, or where active intervention has to take place, those are the dark green bars. So while apathy was present in 70% of the patients as observed, it was clinically significant in only 1/3 of the whole cohort. And that makes a big difference. The presence of the symptom and its clinical meaningfulness are different things. Yeah. So again, if you look at cluster these symptoms in the syndromes, the most prominent one was hyperactivity, followed by the apathy, psychosis, or affective symptoms. Now, again, when these patients were followed up for a long time, because that's an ongoing cohort, they found that while psychosis and apathy increase with the increasing severity of the illness, but affective remains somewhat the same, and hyperactivity is all up and down. So this can present, be treated, and then reoccur at a later date. There's no set pattern to it. Now, I thought I'll just bring this slide here because this is a new diagnosis which is coming in now, and they're recognizing it as mild behavioral impairment. And the important thing is that it is seen in patients where there's persistent neuropsychiatric symptoms That's what this NPS is, persistent neuropsychiatric symptoms. In those people who do not have cognitive impairment, or at the very most, they have mild cognitive impairment as a diagnosis, which Dr. Tandon will be talking about later into the session. But its importance is that people who get this MBI are more likely to go on and develop Alzheimer's. That's the thinking right now. How it will pan out in 5 years' time, we'll just have to wait and watch. So how do we treat it? I think as all us are experienced and qualified psychiatrists, we know antidepressants for depression, anxiety, antipsychotics for hyperactivity, or sometimes for sleep, or mood stabilizers. So it depends which is the most predominant symptom and which is the target symptom or syndrome that we make a choice of antibiotic. The only thing is there are no specified doses for these medications for use BPSD. So we go with the same motto, start low, go slow. Now, sometimes it is said that the dose in an older adult is half of the dose in a young adult. That's a rule. So, like escitalopram, the max dose will be 20 milligram in an adult patient. It would be 10 milligram in an older adult. Now, this is my personal opinion, and I have modified the motto: start low, go slow, but don't stop till maximum tolerated dose. The last phrase, MTD or maximum tolerated dose, means that either the patient develops side effects or they are just intolerant to that dose. And that can be either 40 milligrams of escitalopram or it can be 5 milligrams of escitalopram. Very early in the treatment, we find that it's starting with 5 milligrams. And sometimes I have even started with 2.5 milligrams. Patients are intolerant to it, which necessitates a change. The same applies to any therapy for an older person. Keep the doses as small as possible. Keep the number of medications as small as possible or as few as possible. Right. The thing in red about the increased mortality risk, I'm sure everybody must have heard that about 20 years ago, this study came from Canada where they said risperidone was responsible for death of older adults with cognitive impairment in nursing homes. And hence risperidone earned itself the black box warning from FDA. So that's why this statement is there in the red. But we'll talk about it a bit later when we come to a network meta-analysis, why risperidone was to take the blame for it. And this is a network meta-analysis with 82 RCTs and well over 20K patients. And they looked at all these therapies, all the trials where these therapies were used. So it's an impressive bit of work. And when the numbers are large, then we think they are more meaningful. That's the conventional wisdom. Okay, I brought this thing up because everything in green in this graph has got a low degree of bias. Yellow is moderate and red is high degree, or they were not able to take from the papers. The important bit here is that most of it is green, which means that we can say that there was not much bias in the majority of the studies which were included as a meta-analysis. And it's important to take this factor into consideration because that will dictate how we interpret the results of this meta-analysis or any meta-analysis for that matter. Okay, we have got two very colorful graphs or spider-like thingies. The one on the left is the neuropsychiatric inventory, and this is the Cornell CMAI scale. The blue circles are the number of the patients, and this one, if you can see, the biggest blue one is the one, those patients who had the placebo in both the figures. And then we have the individual agents, where there are other blue dots. And the thickness of these black lines connotes the number of trials which have been done. So for example, in the figure on the left, the thickest line is of memantine versus placebo. Again, memantine is donepezil. There are comparisons, but the line is much thinner. Now coming to this figure on the right, after the large number of patients who received placebo, the two largest receivers stand out as being risperidone on the bottom of the screen, and 90 degrees above is the haloperidol. You can see the line between haloperidol and risperidone is the heaviest from what we can make out in the diagram. So the point I was alluding to earlier about risperidone getting the black box warning, the possible reason for it is that all antipsychotics may increase the mortality rate, but second only to placebo. Majority of the patients had risperidone, and that's why the mortality has been flagged up as being coming from risperidone. But that's my hypothesis of my thinking. Okay. Excuse me. So with this background, let's go on to the results. Okay, all these 18 medications were tried against placebo. In this forest plot, there's one big vertical line, which is a line of zero effect. And then the bottom horizontal line is the magnitude of the effect. So the little blue circles denote the main effect size, and the black lines on either side of the circle denote the confidence interval for that standard mean difference. Now, anytime the confidence interval does not cross the vertical line of no effect, it means the study results are significant. And there are only very few studies, in fact, only a couple. One is the second from top, ceteropram versus placebo. And then we have got haloperidol versus placebo, where the confidence interval is not crossing the line of zero effect. And this, the same has been done for people who were rated only on CNAI. And in this, you find that all the lines are going across the line of the confidence intervals are going across the line of zero effect. So that makes interesting. So the authors did furthermore, they found that medications starting from aripiprazole to risperidone were significantly more effective than the placebos. Others were not. So notably, rivastigmine is missing from here. Any other SSRI besides citalopram is missing from here. haloperidol is missing from there. The side effects, the medications which cause side effects more than the placebo. Only two of AKs, galantamine and rivastigmine, and two atypicals, risperidone actually, sorry. Ignore the last bit where it starts with quetiapine. This was to be deleted, but somehow it stayed there. When they put the medications head to head, then quetiapine was found to be the safest. Now, if we take a seat back or a couple of steps back and think, why would that be? To my mind, one comes that quetiapine is probably one of the most sedating atypicals. And hence, its dose cannot be increased very much in a old and fragile person. So that in itself is a limitation on a higher dose, the physical status of the patient. So probably the desired effect of keeping the patient quiet so they do not injure themselves or hurt other persons is achieved at a much lower dose with quetiapine. But again, that's my interpretation of this finding. You're free to draw your own conclusions. So, coming to Indian studies, everybody says there's an epidemic of dementia coming. The numbers of patients with dementia are increasing exponentially. If the numbers are increasing exponentially, then we would expect the number of studies to be increasing as well. But looking at Medline as of afternoon, I could only find 10 studies. 5 are here, and they are dealing with different parts of BPSD. For example, the one from Patna is socio-demographic and clinical details and caregivers distress. The second one is kind of an opinion piece. Raji is exploring BPSD. Lucknow, and that's from my own institute. The chap who did the study was doing his DM in Geriatric Mental Health, where he looked at the correlation between the baseline serum homocysteine levels and BPSDs. Again, a caregiver distress. Emerging treatments, which is a review article. Kashmir, they compared early versus late onset Alzheimer's and the BPSD as it presents. So not much literature. In fact, very sparse literature, considering the size of the country, considering the size, the number of tertiary care institutes which are in India, and the growing number of the patients. Something to note, something which can be modified if we take note now. So now coming down to the ground level, getting the hands dirty. How do you diagnose BPSD in the clinic? So this is a case from my OPD. On the first OPD visit, the patient himself was not communicative, but the attendants or the caregiver said that he has been having complaints for last 3 years, which were forget things of daily activity, repeatedly asking for same things, withdrawn, decreased. And this all increased very much in the last 3 months with sleep cycle reversal, incontinence, irritability, hyperactivity. MMS SE score was very low, only at 10, which denotes by convention a severe degree of dementia. Notably, the illness started only 3 years ago as noticed by the caregivers. And 3 years, there has been a 20-point drop in the MSC scores. Assuming, of course, that the person had no cognitive impairment uh, 3 years ago. Okay. And that was a diagnosis of the senior resident who worked with the patient. We did the dementia screen, we CT, usual finding of CT, global cerebral atrophy, vascular changes, paraventricular white matter hyperintensities on a MRI later on. And the person was already receiving donepezil and namantane from a psychiatrist of the hometown, which was about 100 kilometers away. And to control sleep and agitation, olanzapine, all very familiar prescriptions. So diagnosis correct, patient has dementia, patient has BPSD, treating both. However, the most important thing in those four alphabets, BPSD, is the last one, the D. How does one diagnose dementia based only on history and first time seeing the patient, where it's not difficult to communicate or do a detailed cognitive examination of the patient? Now, ICD-10 requires that the patient should be in clear consciousness. There should be dysfunction in at least two cognitive domains. Now, if the person is hallucinating, they're engrossed in their own world, how does one do formal neuropsych testing? Or even something more, just a step more elaborate than MMSE, which is adult cognitive examination, the Hindi version, which we use regularly. Patients do not cooperate. So how are we giving a diagnosis of dementia when the D of BPSD has not been established? We need a person in clear consciousness who can cooperate with cognitive tests, bedside ones, or even with detailed neuroscience. So that diagnosis is questionable. What does it say? Those complaints are just reflecting a deficit in short-term memory or attention. The second ones are there, but a detailed examination is not possible. So we never gave them a diagnosis. We never ascertained that patient has dementia. And if we cannot ascertain the patient has dementia, just because a CT or MRI is, the opinion of the radiologist says that there's a global cerebral atrophy, then the whole diagnosis of BPSD comes in question. But once the patient has settled down and one can go and do a more detailed cognitive examination, test the cognitive status in the cross-sectionally, and then consider the D of BPSD. It doesn't matter what kind of dementia we are dealing with. Alzheimer's, frontotemporal, Lewy body, Parkinson plus, whatever. The D is very important. And I think Ruchika is going to be talking about diagnosis of dementia and the recent diagnostic criteria for it. So I didn't mention them yet. But do remember, there's no cure for dementia. It's a permanent diagnosis. Once given, they are just saying that we assigned the death certificate for the patient with Alzheimer's who will live 7 to 10 years from that point. And there's no recovery. And caregivers are going through a very hard time in the last 3 to 5 years of that person's lifespan. Right? So what other things to consider before we go on to say it's BPSD? But if dementia is not proved, it can be delirium. The patient may, while there may be a slow cognitive decline over the last 3 years, the patient may have been taking surreptitiously some psychoactive substance and is withdrawing from it. Can it be a late onset psychosis? One thing I would just like to add here, that patients with late type depression can have an MFC scores as low as 20, which is in the same range as mild dementia. But these scores pick up as the depression symptoms improve with treatment. Just something to keep in mind while sitting in a clinic. So do consider, my advice is do consider every other alternate diagnostic possibility before labeling the person as having BPSD, because then we are automatically saying it's got dementia. And once a psychiatrist gives the diagnosis of dementia, people generally do not quarrel with it. And that's the end of the presentation. I end by wishing all of you good mental health. Thank you, Mr. Yadav. Oops, that's us.
Thank you, sir. Thank you very much. Now we'll request Ruchika ma'am to take her session forward.
Okay, I'm muting myself.
Yeah, sure, sir. Once the ma'am's presentation will be over, we'll be taking the question answers together. Ma'am, over to you.
Yeah. Good evening, everyone, and lots of thanks to the organizers for this. So I'll be talking on a bit on cognition before learning what is impaired cognition. So cognition and action of acquiring knowledge and understanding through thought, experience, and the senses. So it includes a lot of things like visual functions, attention, knowledge, language. So basically, it includes the process of existing knowledge and acquiring new knowledge. So once that is abnormal, impaired, that is what is known as impaired cognition or so dementia is basically a syndrome which includes things like impaired memory, thinking, behavior, and ability to basically perform the daily activities. So it includes things like thought and perception. And since time to time, there have been several criteria which have been given to define dementia. The DSM-4 criteria defined it on the basis of the fact that cognitive decline must cause significant impairment in social or occupational functioning and a significant decline from the previous level of functioning. And it has to exclude certain things like strokes, Parkinson's disease, Huntington's, SDH, tumors, some vitamin deficiency diseases, and the things like delirium and the psychiatric conditions. Now, DSM-5 had replaced the term dementia with the term neurocognitive disorder, and it had classified these disorders into what was earlier known as dementia, which was then called major neurocognitive disorder and a mild neurocognitive disorder. So these are the different classifications of different criteria which have been given from time to time. The recent one means that this NIA criteria is that the patient, first is the subjective criteria that even the patient or some person who knows the patient has informed that the person is having difficulty in remembering things and in doing some activities, or the clinician has noticed that there is some problem with the memory of the individual. For that, the objective signs, like once the assessment of the cognitive domains is done, then it is found that at least one or more than one of the cognitive domains that are impaired. However, for diagnosing mild cognitive impairment, the activities of daily living have to be preserved. So, a person who is actually demented is not included in the definition of mild cognitive impairment. A US survey in 2019 done on the primary care physicians showed that many of the physicians do lack technical support, infrastructure, training, and experience to efficiently detect and manage Alzheimer's from the preclinical stages to the stage of minimally impaired cognition and to the stage of dementia. So in that, they found out few reasons why the primary care physicians omit diagnosing these patients, because they might not have sufficient time. Patient might be posing resistance to testing. The cognitive impairment might be in a very subtle stage. They are uncertain how to perform the brief cognitive assessment, and then of course what to do after assessing cognition. And referring to the specialist is the most common practice. Patients also reported that very few of them actually had regular cognitive assessments, and this is the US data in the routine health visits. And less than one ever assessed for the cognitive impairment. So, what are the cognitive domains which we have to test? First is the domains of memory, like 3 hidden items, language, naming function, clock drawing, picture drawing, copy, digit span, conflict, and clock drawing. Screening tests include MMSE, 3-item recall for memory. Language testing may include MMSE and spatial MMSE, the pentagons may be tried. And for executive function, it is the FAB, the frontal assessment battery, may be employed. In the neuropsychology, some tests like the test for the logical memory, visual reproduction, this auditory verbal learning test, cued selective reminding test, verbal learning test, and Hopkins verbal, these different verbal learning tests may be employed. Then these are the different tests which are given for testing the language functions, spatial functions, the adult intelligence, IQ testing, Stroop test. So this was for testing minimal cognitive impairment diseases other than Alzheimer's. Alzheimer's. So now we shall see what happens if we have to diagnose MCI in diseases other than Alzheimer's. Stop share. We were discussing cognitive in people who had Alzheimer's dementia, from the prodromal stage of the mild stage of Alzheimer's dementia. However, for assessing MCI in disease other than Alzheimer's, some other criteria are there, like subjective criteria same, that the person or some knowledgeable informant detects some problem in the patient and the clinician detects some subjective issues with memory. For dementia of Lewy body disease, the objective criteria includes impairment in more than one cognitive domain, especially the attentive or executive domain and or the visual processing domain. And the psychometric impairment has to be at least 1 to 1.5 standard deviations from the normal. The function has to be preserved or minimally affected since it is not dementia. And then there are certain biomarkers like the polysomnographic evidence of REM sleep deprivation abnormality, and the visual hallucinations might be there. For diagnosing Parkinson's disease with MCI, the person must be having an existing Parkinson's disease. There should be an impairment in a scale of global cognitive abilities validated for Parkinson's disease or more than 2 other tests. Psychometric impairment has to be of at least 1 to 2 standard deviations. The person must be functionally independent. In vascular MCI, we test for 4 cognitive domains, that's the executive or attention, memory, language, and visual spatial domains, and out of it, at least 1 or more than 1 should be impaired. Person should be functionally independent. And for Parkinson's disease also, we have to exclude some other diagnosis. And for vascular, we have to exclude the active diagnosis of drug or alcohol abuse or dependence. And of course, delirium should not be there. For Parkinson's disease, the diagnosis of PD should have been, Parkinson's should have been made based on the proposed criteria for Parkinson's disease. And for vascular, we may get some help by doing the neuroimaging. So what is essential for early diagnosis? In Alzheimer's disease, the atrophy of the brain, if we go for neuroimaging, the atrophy first starts in the medial temporal lobe, including the entorhinal cortex and hippocampal area. But functional MRI detects the changes earlier. It detects decreased activation in medial temporal structures and increased activity in the parietal and the posterior cingulate areas. Decreased alpha and beta power in EEG and elevated gamma power has also been shown to be an early change in MCI for Alzheimer's disease. And these changes, once they progress, when the person changes from MCI to Alzheimer's, there is also an attenuated synchronization in all the frequency bands when a person progresses from MCI to the Alzheimer's disease. In vascular dementia, EEG may show increased power and decreased synchronization, especially in the frontoparietal alpha rhythm, compared to people with Alzheimer's. And in DLB, it has been seen that the dominant EEG rhythm is of less than 8 Hertz. And so the EEG can help in diagnose these people early. Deep learning, the evoked potentials, etc., may also be helpful. Worldwide, the prevalence is increasing, as we all know, partly because of the aging population. Now, what is essential is that we must find out if a person is having irreversible causes, modifiable causes, or reversible causes. So it is the reversible causes and the modifiable causes which we want to address. Modifiable causes, the commonest ones are diabetes and hypertension. Hearing loss, poor diet, alcohol, stresses, head injury, and of course MCI can also be modified. The reversible causes may include some normal pressure hydrocephalus, certain tumors, encephalitis, meningitis, some other infections, the endocrinal causes, and others. So in around 2 to 23% of the people, the causes may be reversed. Some other metabolic causes like liver disease, respiratory disease, renal failure, epilepsy, depression, what is known as pseudo dementia, can also be one of the reversible cause. Irreversible causes are ones which the people are most afraid of, which includes most commonly Alzheimer's dementia, dementia of Lewy body disease, vascular causes, frontotemporal dementia, and Parkinson's disease associated dementia, and the other causes. So this shows the prevalence of Alzheimer's in different states of India. So the things which are marked with red have the highest, and orange have the highest prevalence of Alzheimer's, and we can see that in the urban areas the prevalence is lesser in comparison to the lower to the rural areas, and the prevalence is more in women in comparison to men. In those who have lesser education in comparison to those who are more educated. And the most common dementia worldwide is the Alzheimer's disease, followed by vascular dementia, and the other causes come up after that. So it is seen that in Alzheimer's dementia, because when a person, in the elderly people, the prevalence keeps on increasing because of the formation of amyloid plaques, neurofibrillary tangles, and also because of the loss of cortical neurons. Clinical things may be like memory impairment, and important feature once a person is demented is that they are unaware of the difficulties which they are. It is the caregivers who are actually worried about the patient, but when we ask the patient themselves, they deny having any problem. Or they may tell things like, I'm having some backache or some other trivial problems. Cognitive decline in difficulties in driving, shopping, housekeeping, language is impaired, apraxia there, visual spatial deficits, delusions, and in the end stage, a person becomes rigid, mute, and incontinent. So what is dementia and what is not? So an elderly lady who might be searching for her keys and they may be forgetting where they have kept their spectacles, though they may be wearing the spectacles. That is a very common thing, but it is actually might not be dementia. So once a person keeps on remembering the things on cues, usually it is not dementia. Vascular dementia is another common type, and so the cognitive decline which occurs as a consequence of cerebrovascular disease is known as vascular dementia. Some people may have both the features. They may be having Alzheimer's as well as vascular changes. So we have to treat both. And so the clinical feature might be that they may be having recurrent strokes. So even if the strokes are not visible, they may be having stepwise increase in the symptoms of dementia. And then some associated features like hypertension, diabetes, coronary disease, etc. be there. Binswanger syndrome, like diffuse white matter disease, like coronary infarcts, etc. may be seen on imaging. And they may present with associated gait disorder, especially involving the lower limbs. The vascular Parkinson is maybe there associated with them, and they may be having pseudobulbar affect or emotional lability. Frontotemporal dementia, which often begins with behavioral disturbances, unlike an Alzheimer's in which the social graces are quite preserved till late in the disease. Patients may be hot-tempered, disinhibited, memory and visual spatial skills may be spared till late. It is the judgment, the frontal lobe dysfunction, which is most often seen. They may present with echolalia, in which they keep on repeating what the examiner says, or palilalia, in which they may repeat their own words. And there may be an overlap with other tauopathies like PSP and corticobasal degeneration. And it is most often that these people do visit psychiatrists rather than neurologists because they are having a lot of behavioral symptoms. And what actually happens is that people think that they are actually having some psychiatric disturbance, and it is the organic syndrome of frontotemporal dementia, which is often missed by many of us. Coming to dementia of Lewy body disease, it is more prevalent in the West than what we see here. It presents with Parkinsonism, fluctuations in the cognition, visual hallucinations. And these people may be very sensitive to the adverse effects of neuroleptics. So we have to be very careful when administering neuroleptics in these people. A characteristic feature is the cognition has fluctuations, which means that for 5 or 6 days or maybe few weeks, the people may be very good. They may be recognizing people. They may be having a very good memory. And then for the next few weeks, they may be having a decline in memory and not performing any of their day-to-day acts. And it is important that it is not the daily fluctuation in cognition which occurs. It is the cognition fluctuation which occurs in a few weeks or days at least. Normal pressure hydrocephalus, of course, has to be excluded. It includes what we have all studied: dementia, gait instability, and urinary incontinence. And it is the later two features which are usually seen first. And dementia only occurs once it is not treated in the later stages. Symptoms progress over weeks to months. And it is may be diagnosed using the CSF examination. So the normal pressure hydrocephalus can be diagnosed by withdrawing CSF. So how to diagnose a person of dementia when they come in the OPD? Like any other case, we have to make use of history, symptom analysis, focused physical examination, cognitive and neuropsychiatric examination, and the few relevant lab tests. Clinical symptoms include cognitive impairment, functional impairment, neuropsychiatric manifestations, as we had seen in the previous slides, behavioral disturbances, mood changes, personality changes, sleep disturbances. So history has to be taken in chronological order from the loved ones. Mode of onset may be abrupt, like in cases of vascular dementia, or may be gradual in most of the other cases. Progression may be stepwise versus continuous decline, as we had seen. Duration of symptoms is important. So the reversible causes may be having less duration of symptoms. Medical history like hypertension, diabetes, etc. may give a clue to the presence of things like vascular dementia. Family history may be important in some cases of dementia, for example, in frontotemporal dementia, ALS syndrome. Socioeconomic history is, of course, important because dementia is more often seen in those belonging to lower socioeconomic strata. Evaluation for toxic agents is essential to rule out certain toxic causes like aluminum, etc., which may cause dementia. Then the examination has to be done of different lobes, functions have to be tested. Of course, the focal neurological deficits have to be seen to rule out strokes, extrapyramidal signs to rule out Parkinsonism, which may be associated with things like dementia with Lewy body disease, frontotemporal dementia, PSP syndromes, and also in Parkinson's disease dementia. Vision and hearing screening is very important, especially in the elderly population, because the people who may be having impaired senses may not be actually demented, but they may behave like those who are demented because they may not be understanding exactly what the caregivers are actually, what the family members are actually wanting them to do. The cardiac and pulmonary evaluation is, of course, important for ruling out some other associated diseases. So diagnosis could be that of a major neurocognitive disorder once the cognitive decline is seen to the extent that the activities of daily living are impaired. So decreased memory and performance on cognitive tests may be seen. MMSE is a nice screening test. MoCA is more often used. FAB may be good for assessing the frontal lobe functioning. And then there are different standardized tests which may be available. Some of them might be paid. The diagnosis is made on the basis of age, educational level, cultural background. Females are at higher risk of being diagnosed at a later stage. Recreational or occupational activities which require complex cognitive tasks may be earlier affected. And so for diagnosing these patients early, we have to find out whether their recreational activities are affected. To rule out other causes, we may have to go for CSF examination, other tests like HIV ELISA for neuroinfections, homocysteine levels, vitamin B12, very important, folic acid levels for ruling out the treatable, the modifiable causes of dementia, thyroid levels, cortisol levels, angiography, 2D echo, carotid Doppler. For ruling out Wilson's disease, certain tests, and for the autoimmune encephalitis, which may sometimes present like a dementia, though the history is usually short, paraneoplastic and other autoantibodies, certain tumors, and then for ruling out malignancy, certain specific tests, sometimes drug levels, some alcohol levels, the liver and renal function tests, CSF pressure measurements, screening for depression, and refraction for sight and hearing examination. So the differential diagnosis may include things like delirium, MCI, age-related cognitive decline, mentally subnormality, schizophrenia and other psychiatric causes, and even alcohol use. So as we all know that prevention is better, but we don't know how exactly to prevent dementia to a whole extent. But then there are certain things which are helpful, like the use of vegetables. More often, they contain lots of antioxidants. The use of Mediterranean diet, prevention of road traffic accidents, keeping oneself cognitively using the brain to more extent, reading newspapers, solving puzzles, crosswords, things like that. Because more often the brain is used, more often it is likely that the things will be, some of the fund of knowledge will be preserved. And of course, all these interventions should be started before middle age for them to be more effective. The treatment includes use of cognitive enhancers. The traditional ones are usually effective once the person lands up in the stage of dementia. And these include the cholinesterase inhibitors, which are effective for Alzheimer's, rivastigmine, which is an acetylcholinesterase and butyrylcholinesterase inhibitor, which is effective for Alzheimer's as well as for Parkinson's disease-associated dementia, memantine, which is an NMDA receptor antagonist, which is effective for Alzheimer's and vascular dementia, the SSRIs for associated psychiatric symptoms like depression, though they may be used, they have to be used carefully, especially in the elderly population. The management of blood pressure, blood sugars, and lipids for taking care of vascular dementia, cognitive exercises to keep the brain healthy. So physical as well as mental exercises are helpful. Diet, healthy diet, a balanced diet, which includes proper use of green leafy vegetables, fruits, nuts, and protein. Environmental modification. Once a person lands up in dementia, we may have to modify the environment, like the use of diaries for them to remember their day-to-day activities or their appointments, for example. We may have to use railings around the bed if the person has a tendency to fall. We may use some alarms to make the person remind these people of their what work they have to do. But then, of course, the diary keeping is actually, it doesn't actually prevent, it just helps a person, but it is better if they are encouraged to remember the things on their own, because then the dependence on these things would be less, till at least the stage when they are not able to remember the things on their own. So it is actually a team approach which is needed for the management of these people, which includes psychologists, psychiatrists, physiotherapists, occupational therapists, neurologists, sometimes speech therapists, and not to forget the caregivers. The burnout prevention strategy is also to be given to the caregivers. 21st September is a day which is devoted to Alzheimer's prevention. Then coming up to certain newer treatments. So newer treatments are needed, especially for management of the early cases of dementia, and also those who are in the stage of minimal or mild cognitive impairment. So there are lots of trials which are there. Two antibodies against amyloid, which is actually accumulated in the brain cells. So those two have been approved, 2 or 3 have been approved by the FDA, which includes lecanemab and donanemab. These are two of the antibodies which are against amyloid. Both are administered by intravenous routes, and it is seen that after donanemab is given once every 4 weeks, an infusion once every 4 weeks, and lecanemab is given once every 2 weeks, and both have been found to clear amyloid for brain in 18 months in cases of donanemab, and lecanemab is it also helps in recovery from the removal of amyloid. The adverse effects are similar in both of these, which includes brain edema, bleeding, and seizures secondary to the bleeding manifestations. And so MRI has to be advised in these patients before administering these antibodies. Then there is another antibody which may be administered by subcutaneous route, which is undergoing a phase 3 trial, that is remternetug, and in 75% of the people were shown to have cleared amyloid from the brain in 6 months using this antibody rather than donanemab, in which it takes around 18 months. Adverse effects are similar in all these 3. Then buntantab decreases the production of amyloid precursor protein. So it acts at the previous stage of the production of amyloid protein. It also affects tau protein in the blood decreases the level of tau protein in the blood. So it may be effective in tauopathies also. Phase 3 trial is coming up and it has shown improvement. It may show improvements in memory and thinking scores after 12 weeks. Semaglutide improves insulin sensitivity and it may help in preserving the brain cells. Serocatinib may act on synapses. So in mice, it has been shown that synapses may start working after we administer this. Still undergoing trial. Some other things like beta and gamma secretase inhibitors are being tried, and some immunomodulators, some heart disease drugs, newer targets are being explored. Hormonal replacement therapy was tried, but it had not been found to be very helpful in preventing progression in Alzheimer's dementia. Then antibodies against the tau microtubules binding region of tau, they are under trial. And these are different molecules which are helpful in preventing tau aggregation and in the formation of phosphorylated tau. Escitalopram could selectively attenuate the phosphorylated tau. It may be helpful in tauopathies. Then modulate this positive modulator of hepatocyte growth factor signaling. It may be effective. So all these different agents are being tried in different trials. Nilotinib is a tyrosine kinase inhibitor. It has been found to promote amyloid beta and tau protein degradation. Semaglutide and this tricaprilin, which is a semi-synthetic medium chain triglyceride, it is metabolized to ketones. So it may help in providing an alternative energy substrate for the brain. And so brain cells will function better. Some mast cell and microglial activity may be inhibited, leading to lesser destruction of the cells by and oral tyrosine kinase inhibitor. And some cannabinoid receptor antagonists are also being tried for agitation in Alzheimer's. Then things which are derived from yeast, which may reconstitute gut microbiota, caffeine, which may reduce the formation of amyloid, spironolactone, which may have an anti-inflammatory action, and hydralazine, which may act as an antioxidant, are all being tried. Last but not the least, it is not only the medical treatment which is important, but self-care, especially when the people have not yet progressed to dementia stage. The person must be physically as well as mentally active. They must eat healthily. They must stop smoking and drinking, go for drinking alcohol, get regular checkups with doctor, write down everyday tasks and appointments to help you remember important things, keep up with your hobbies, try new ways to keep yourself active, engage socially, and also have certain plan for decision making. Once you will not, if you might not be able to communicate these decisions at a later stage, join a local support group. So all this is an advice which has been given by WHO to the people who are suffering from dementia. A global action plan on public health response to dementia 2017 to 25 has been made up by WHO. Global Dementia Observatory is there, and a knowledge exchange platform. So these are all the activities which WHO is conducting. So what is important in the management of people is that we must take these people seriously. They may be any one of us, our family members, our patients, anyone. So we have to just be vigilant and just take them seriously and be helpful and help them as a team and as a society. Thanks for your attention.
Thank you, ma'am. Thank you very much. I think, Nilesh, we can take up the question answers.
Yeah, sure. Sure, sir.
Yeah.
So, sir, I have pasted in the chat box. There are few questions. So I have pasted over here. So the first question is, ma'am, any clinical evidence do we have on acetylcholinesterase inhibitors which have a activity in plaques?
These actually, the acetylcholine esterase inhibitors, they are actually most of the study is actually done on the increasing the activation of the brain cells. So that is the most focus of research is on that. And amyloid plaques, there are some other antibodies and some vaccines and the things like that which are actually being tried on the amyloids. So there are two different things which are actually being, 2 or 3 different mechanisms of actions which are actually being tried. So one is on the basis of the improvement of the cognition, and then the other is targeting the disease process. So the amyloid is being targeted by some other things like antibodies, and so these are 2 or 3 different methods by which the disease is being targeted to be treated.
Ma'am, fair enough. One more question came on the same thing from the same person. Is there any same relevancy seen with the tau protein also?
Yeah, so there were so many like molecules which I had shown in my slides, which are being actually tried on the tauopathies. And you come to the treatment part, these were the different vaccine-based and antibody-based targets which are being actually tried for the treatment of the clearance of the tau proteins. So there are different kinds of drugs which are actually being targeted for tau as well as for the amyloid plaques. And the cognition enhancers, they are more effective once the person actually develops dementia. And there is some, but then of course, what we see in our clinical practice, they do come up at a later stage, and many of them, they have tauopathies, and we do give the cognition enhancers in these people. And many of them, they do tell that the patient is stable for some time at least. We get whether because of the action on tau or if it is on amyloid, that is another story. The progress is not fully, the progress of disease doesn't stop, but then we do get some benefits by the use of the cognition enhancers.
Okay, ma'am. The second question, ma'am, is there any suggestion or a choice of drugs, ma'am, in the Lewy body dementia and vascular dementia?
Yeah, for the Lewy body, and what was the other one?
Vascular.
Vascular, yeah. So for dementia, what literature is showing that who are having dementia, as for Alzheimer's, rivastigmine works for people who are having Alzheimer's, DLB, as well as for those who are having the vascular dementia. So it is quite some broad spectrum kind of a agent, and donepezil mainly helps people who are having Alzheimer's, but that is only for dementia part. Now, apart from that, there are some other associated symptoms which are actually seen in people who are having DLB. So for DLB, what is important is that we may not be able to give all the antipsychotics. So we have to give them in a very low dose, and also these people may be having the Parkinson associated. So for management of Parkinson's, syndopa this works very good in these the levodopa carbidopa combination that works very good in these people who are having dementia of Lewy body disease. They are very effective. This is a very effective agent for them. And for vascular, we have to also take care of the lipid lowering things and the antiplatelet agents and the associated control of diabetes, hypertension. So all these things are also important.
Nilesh, any further questions?
Yeah, so one more question we have.
Yeah.
Any evidence where combining with anti-Parkinson's medications with rivastigmine patches?
Anti-Parkinson's medication.
Yeah.
No, they have an entirely actually. I have actually not exactly. I'm not aware of any studies which are for dementia if they are like combining, but then definitely for they are acting on two different things. Like Parkinson's disease treatment is being given to take care of the Parkinson is the extrapyramidal features, and rivastigmine patches are actually they are being given for taking care of the cognition part. So they definitely they can be combined. We actually give both of them together for management of different symptoms. Like if a person is having Parkinson's disease with dementia, so till the person is having only Parkinsonism, we'll give this levodopa, but or the other drugs for Parkinson's. But once the person develops dementia, then definitely we have to add something. So we do give rivastigmine patches in the people.
Okay.
The same is true of the other kinds, Parkinsonism associated dementias. Like in frontotemporal dementia, there are very few things which work, but but definitely from clinical experience, we can say that rivastigmine works in these people, and it has plus the patches have one more advantage. The advantage is that if the person is like having lots of behavioral issues, so they might not be able to accept the other like too many pills and all. So these patches are actually applied on the back and the areas where the person is not able to actually remove. So that so we do give this treatment.
Fair enough. So these are the questions we had, sir.
Yeah. Nilesh, when you are done with your questions, because two eminent doctors dealing with dementia is there, Shrikant sir, one thing I like to understand, see, as it has been come out of this progression, that it is a disease which slowly progresses. And if it can be addressed at a very initial phase, definitely the longevity of the treatment and good life to the patient can be given. So what do you suggest that what should be like, I'll give an example. When it was a depression, initially it was talked upon. So many programs the psychiatrists have done with the physicians so that they can understand what exactly are the signs and symptoms of depression. And if they are finding it difficult to handle, immediately they recommend to the psychiatrist. So similarly, I like to understand on same lines, but still there is a lot of chaos in identifying the initial sign and symptoms of dementia and Alzheimer's disease. what you suggest that what kind of the future course of the awareness programs we should run, which should be helpful in identifying the patient is suffering with the early stage, whether he is going to any specialty. If it is coming to psychiatrists and neurologists, definitely they can evaluate and they can understand this patient is developing this kind of the disease. But I'm talking about whether he is going to any kind of the specialty, and if with some of the question they can find that they're developing this kind of thing and they're referring, this can help them to do further better for them. So what you suggest for this, sir?
Are you saying you are going to finance a program? You can come up with something?
We can come up, sir, but always it will be you who will be instrumental. The pharma companies cannot be do it on a alone or a loner basis. If it is done in the collaboration of some societies and eminent institutes like KGMU and SGPGI, definitely it can be done better. Like,
Okay, let me take you a step back.
yeah,
Depression and dementia.
yeah,
There's a theory that depression is possibly the first sign of a dementia, which comes anywhere 5 to 10 years later down the line. Okay. Somebody who develops at the age of 70 years, first time a depressive episode, then it is like that later on they are more likely to develop a dementia, Alzheimer's. The second thing which we have seen in our clinics, and we do a very rigorous objective assessment of every patient of depression, which includes a severity rating on Hamilton Depression Rating Scale, Geriatric Depression Scale, and Hindi Mental Status Examination. Every visit. I think I have mentioned this in my lecture before, that patients with depression can have cognitive deficits with HMSE scores or MMSE scores as low as 20, which is in the range of mild dementia, right? So there is an overlap somewhere. And one of the things that we found was homocysteine levels are low in these patients. We are in fact in the process of using our database with artificial intelligence to look at homocysteine as one of the predictors for depression and cognitive deficit. So we are in working with Noida Amity University with their AI department. So I think that if we can go to primary healthcare centers or even CHCs, evaluate everybody who's 60 years old on 2 questions of depression. Ask them, take a blood sample, check their homocysteine levels, which Ruchika also mentioned, homocysteine vitamin B12. I'll add vitamin D3 to the list as well. And if their homocysteine levels are high, then we treat it. Because increased level of homocysteine is actually neurotoxic. So it can damage the neurons there, or at least impair their efficiency. I think that will be kind of a primary prevention program where we target these 60 plus people to start with. And giving vitamin B12 is a cheap therapy.
wonderful, sir. In fact, this your suggestion is something which can really worked upon, and it can help. Like 2 important points which I understood, that anybody who is 60 plus, he should be evaluated. Like nowadays, anybody who's 40 plus, he goes for checking up their blood sugar level monitoring, their blood pressure monitoring, so that even if he is developing this kind of the diseases or not, after that it can be preserved. So if patients of 60 plus can be evaluated on the depression part and homocysteine level part, definitely this can be the precursor which can help them to suggest better kind of the treatment if they are diagnosed with the initially suffering with the Alzheimer dementia kind of thing. Thank you,
Well,
sir. Thank you very much.
I'm thinking that it may be preventive for dementia later on, but we need at least a 10-year longitudinal study
True.
to go into that.
Definitely. Definitely.
Yeah, sir.
So,
So one more question, sir, is there? This question is for Dr. Shrikant, sir.
Yeah.
Sir, what is the drug of choice of yours for Alzheimer's dementia at the late stage?
Nothing works. That's very honest, brutal opinion.
Okay,
It only needs TLC,
okay, okay.
tender
So,
loving care.
acha, nice. So,
So
one
Nil-
more is there. So why donepezil is more preferable over rivastigmine in terms of initial stability of patients by Dr. Amit Kumar.
See, I find that all the four of them are equally effective. Donepezil, I think, was the first one to come to the market, and it has just captured the imagination. My personal choice is with galantamine or rivastigmine because they inhibit both the acetyl and butyl cholinesterase inhibitors. Right. So, and with rivastigmine, again, I prefer to start on oral, and once the tolerability has been established, then switch to the patches because that gives a more steady flow of the medication. But again, that's my personal idiosyncrasy. Research has not shown there's a difference between them.
Okay. So the last question is, sir, role of CBD in having therapeutic potential in reversing the certain cognitive impairments.
CBT as in cannabidiol?
Yeah, role of CBD in having therapeutic potential in reversing the certain cognitive impairments by Dr. Anurag Verma.
Well, what I'm asking is, does Anurag mean CBD as in cannabidiol, which is coming out of cannabis? Okay, I'll take it as a yes from your side. Now, cannabis receptors, like melatonin receptors, are widely distributed in the brain, but they have not been studied as extensively as the serotonin or dopamine ones. And that's possibly because of the more political than scientific reasons. So, yes, cannabidiol has been, or the cannabis receptors CB1 and 2, both are implicated in many things. They are implicated with obesity, they are implicated with depression. They are also supposed to be beneficial for cognition, but rigorous scientific multiple studies are not there, which is mainly because of legal reasons.
yeah. Nilesh, any further questions?
No, sir. All questions are being pasted here.
Yeah.
And all
So,
clear.
with the permission of Shrikant sir and Ruchika Tandon ma'am, if you permit, we can close this the session, ma'am and sir.
We were waiting for you to permit us to leave.
No, no, sir. It's always, in fact, you won't believe for the very few programs I have seen, which has gone up to 10 p.m. and still the live streaming is there and the audiences were always there. Just now, Nilesh briefed me for this through my WhatsApp. So this was something which was really very interactive, and that is why I ensured that I'll be on this platform because see, the kind of topic which has been chosen today for the today's discussion was the area of interest of so many doctors. They wanted it to be there. And once it is coming from the eminent doctors like you and ma'am, Ruchika ma'am, those who are doing involved work, aggressive work in the field of dementia and Alzheimer's, definitely people were there on the live streaming still to understand more about this. And that is why I asked, because we are working now aggressively on the Alzheimer dementia, and the gaps which are coming out is that awareness to the other specialties are also not there. Because I'm trying to understand, as long only neurophysician and psychiatrists will work on this, definitely it will not be working that much, because our population is almost 10-12,000 only. But the population of other specialists are many more. And what you suggested, that the exercise should start from the PHC level. So huge, humongous work is there in front of us, and definitely we'll be looking forward to associate with some of the programs so that we can take it forward. So it is time to say thanks, sir. Thank you very much, Shrivastav sir and Tandon ma'am, that first of all, you agreed to become the speaker of this program, and you prepared the slides with the full intent to deliver the core message of this program. So thank you very much. I'll be thanking to all my doctors, those who are still attending this program on the live stream and making this webinar one of the successful webinars. For that also, I'm thanking you, all of you. I'm thanking my team of IT who's still there with us to for the flawless telecast of this live webinar. And thank you for my team, Hetero, for organizing and arranging this program. So thank you very much. Thanks from the core of the heart. Thank you, Shrikant sir. Thank you, Ruchika ma'am, for making this happen today. And this was really a wonderful program. And one thing I'm telling you, that this is a recorded session. Those who couldn't attend, this wonderful video will be going to them. Only thing will be that the better kind of the sound quality, and our pictures will not go. Only your Shrivastav sir's and Ruchika ma'am's videos will be going there. So that will be given to more and more number of the doctors so that they can get benefit out of this wonderful program. Thank you, sir. Thank you, ma'am.
Thank you, Pathak.
Thank you.
Thank you.
Thank you, sir. Thank you, ma'am.
Thank you so much, sir. Thank you so much, ma'am. Thank you.
Yeah. Ms. Ravli, now we can stop the live streaming and close the program.
Sure, sir. Thank you for your time.
Thank
Yeah.
you. Thank you very much.
You too. Thank you, Ravali.
Yeah, thank you, sir. It's my pleasure.
Yes.